This is Lecture 3, the assessment interview, and it corresponds with Chapter 6 of your textbook. Okay, getting into the chapter material. So assessment in clinical psychology is something we're going to be discussing in the next few chapters. This is going to be more focused on the assessment interview. And the purpose of assessment is to evaluate an individual's strengths and weaknesses, to conceptualize the problem that they're coming in with, as well as possible etiological factors, so factors that may have caused that problem, and then to come up with a preliminary idea of how to treat that problem, so a prescription for alleviating that problem. And all of these things lead us to a better understanding of the client and what can be done to help that client. It's an ongoing process, so typically a client will come in for an assessment at the beginning of therapy or for a number of other reasons, and you just get a snapshot of a person when they come in. There's a lot of information that you're not getting about that person. You're only essentially getting what they're telling you or what you can observe. And so in psychology in general, we consider assessment to be something that's ongoing. We're always staying open to changes in our conceptualization of a person. And assessment is incredibly important because our ability to treat any psychological problems is directly related to our ability to define those problems. So if we can't figure out if we can't conceptualize what the person is dealing with, if we can't kind of put it into a category of this person is depressed or this person is dealing with psychosis, then we don't know how to move forward in helping that individual. Any assessment begins with a referral. And a referral can come from the individual. So someone might say, I'm having, trouble with life right now, and decide to make an appointment with a psychologist. It can come from a parent, especially when they're, in the case of children. A friend might connect somebody to a psychologist, teachers, the treating psychiatrist. So if somebody goes to a psychiatrist for medication and the psychiatrist feels that person could also benefit from either psychotherapy or additional diagnostic clarification or a number of other referral questions, they might refer for an assessment. And excuse me, and a judge. So we'll talk about this a bit more in the forensic unit, but there can be court-appointed assessments which come with their own host of kind of ethical issues and also precarious clinical situations. Those can be especially challenging assessments. So the referral question is what aspect of the patient's behavior needs attention or clarification. The referral question might be something like diagnostic clarification. What is the diagnosis of this person coming in? It could also be something like what is this person's cognitive functioning. So it might be that they're not necessarily dealing with any mood symptoms or psychosis symptoms, but appear to have maybe impaired cognitive functioning. An example would be that recently, so I've told you before that I work in an outpatient psychiatry clinic, and everyone I work with are wonderful, talented clinical social workers. So I'm the only face of psychology in the on the team, and so I'm as the psychologist, I have the most experience with assessment, and so often I get referrals from my fellow clinicians who referrals for assessment for their clients. So recently, one of the other clinical social workers asked me if I could maybe clarify some of the cognitive symptoms in an individual that she's working with who has depression and substance use, but for some reason, and is working through college, but is for some reason unable to complete a math course. So this person has failed a math course 3 times, and she feels like there must be something else going on here that is not accounted for by his substance use and depression symptoms. And so the referral question is, what's his cognitive functioning, or what might be impeding his ability to be successful in these math courses, and so I will design an assessment to address that specific question. So there are many factors that influence how a clinician might decide to assess for the referral question. One of these, essentially the clinician's training and theoretical orientation, as well as what's available to them in terms of assessment instruments, could all be factors. So 2 relatively common orientations are psychodynamic and cognitive behavioral. A psychodynamic clinician may ask about early childhood and interpret somatic symptoms as indication of repressed emotions, because early childhood experiences and also kind of the repression of emotion are big components of psychodynamic theory, which is something we're going to cover later. A cognitive behavioral oriented clinician may ask more about kind of current thoughts and behaviors and interpret headaches as more maybe an indication of job stress. So they may conceptualize even somatic symptoms differently. Choice of assessment instruments, somebody with a psychodynamic orientation might use projective tests to assess underlying processes. So we'll discuss that, I think, we'll discuss that more in the psychodynamic section, what projective tests are. But the Rorschach test, like inkblot tests, are an example that you might be familiar with. And then somebody with a cognitive behavioral orientation might use more objective tests to assess relationships between behavior and symptoms. So someone with a cognitive behavioral orientation would typically use questionnaires, structured interviews, things that maybe are considered to be more objective measures of human behavior and thoughts. So an example of how I, as a clinician, am addressing this referral question that I mentioned before, where this individual is coming in with some difficulty passing this math exam. My training is mostly cognitive behavioral, although I consider myself like eclectic or integrative, which means that I borrow from a lot of different orientations. I kind of, whatever is evidence-based and whatever works for clients in my experience is what I use. I choose not to stick to one specific orientation, but I am trained more cognitive behaviorally, so I tend to use objective tests. So this individual is coming in and I'm going to give him assessments for ADHD. He has a childhood history of ADHD, and so I'm going to check and see as an adult if he still suffers from symptoms of ADHD. I'm going to look at his current level of depression, because depression can affect somebody's ability to function in a classroom setting, and I'm going to do some cognitive tasks. I'm going to administer essentially an IQ test that covers a range of different cognitive domains to get a sense of maybe if he's just not cognitively capable of handling the material at the pace of this particular course. And I'm also going to do a semi-structured interview with him because I want to get a general sense of his perceptions of why things aren't working out at college and with this math course right now, and just get a general sense of how he's functioning in his life right now. Interviewing is complicated and kind of abstract, and there are many different ways of doing it, and as many ways of conducting an interview as there are people conducting them. But there are some general characteristics that are shared. So an interview is an interaction between 2 people, and each person, both the assessor and the person being assessed, contribute to the dynamic of the interview and influence the other person. And this can get rather complicated, and there's a whole body of research and theory about how to manage and sort of assess and be aware of the interaction between assessor and person being assessed. Interviews are goal-oriented. You should go into an interview knowing what information you were hoping to get out of that interview and having a plan of how you're going to get that information. And interviews are, again, kind of complicated because they fall somewhere between sort of like more normal human interaction of a conversation and an actual psychological test. So it has components of a test where there are often standardized questions that you're asking somebody, or they are completing standardized tests later in the interview, but they are conversational. And when you're asking somebody about sensitive information, which is almost always the case in a psychological interview, you do have to be a human. You have to be a professional human, but you have to be a human. So it's more purposeful and organized in a conversation, but it's not completely formal or standardized like a test. And this is, I think, a lot of the reason that so much education is required for somebody to get to the level of being a really talented interviewer. It seems like a simple skill that we all have, but to be really skilled at it and to be a very good interviewer takes years and years of practice. And I think also just some talent as a person in working in interpersonal settings. So interviewing is absolutely an art. It's a skill, but it's an art. And knowing when to probe, when to ask for follow-up questions, or when to leave something alone, when to be silent, when to ask more questions, when to be more direct, or when to be kind of indirect. It's hard to quantify these things, although many people have tried and made a valiant effort, but there also is just kind of an art and a feeling to it. As I mentioned before, interviewing is something that to do it well requires a fair bit of training, and this is usually done through intensive supervision experiences. So as a clinical psychology trainee, I am in my 6th year of intensive supervised clinical work, and so this starts at the beginning of your training as you're probably going to be observing or watching a skilled clinician do interviews, and then you might do those interviews with the clinician in the room. As you get more a little better at interviewing, you might record your interviews, and finally you probably get to a point where you just do the interviews by yourself, but if there are any issues or questions that come up, you would take them to your supervisor. There are lots of different styles and techniques, as I mentioned before, as many styles and techniques as there are people doing the interviews, but there certainly are some general rules and tips that work for most people. One thing that a lot of people may not consider at the beginning of being trained to do interviews is the physical arrangement of the room. So you're going to be doing interviews in a lot of different types of settings, in a outpatient clinic like mine, where I have an office and the patient comes into the office. A lot of people, like my colleagues who do school mental health work, they'll do an intake interview in the school during school hours. Some other people might go to somebody's home. So if there's more intensive cases or people who have difficulty leaving the home, the clinician might go to that individual's home. And so privacy and protection from interruption have to be considered in this. And this can be done a variety of ways. Obviously, being in a room alone and closing the door is one way to do this. There's also those soundproofing machines, the little like white noise machines. Ideally, if we can control the interview room, it would be kind of tasteful but neutral, so not too drab and dull, not looking too much like a hospital room, but also not having too much information about ourselves as clinicians. So you don't want pictures of your friends. Some people will have a picture maybe of their kids. That's kind of a personal choice to make. My office is extremely neutral, so my preference is to really not give much information about myself, because I think that can kind of it's not important for the person coming in to know very much about me, I think. And I think it can impede on the therapeutic process and the assessment process sometimes if they kind of have too strong of an idea of who I might be in their head. So yeah, so my office is very neutral with about like 2 pictures that are relatively pleasant, and then really not much else. Note-taking and recording is necessary, but I think a lot of beginners will take kind of obsessive notes, so take way too many notes or take not enough notes. And ideal is kind of a moderate amount of note-taking, because anytime you're taking notes, you're looking down at your paper, and that means you're not making eye contact with the person that you're interviewing. Your book talks about computer interviewing, and this is something that I honestly haven't encountered much in practice, and I don't think it's used very often, but I think your book brings it up as kind of something that may be more prevalent in the future. So in a computer interview, an individual would respond to questions either presented verbally or in writing on a computer, and it would assess clinical history, specific problems and diagnoses. As the book mentioned, it is becoming more popular. It has 100% reliability, which we'll talk about a little bit later, but if the computer is asking the questions in exactly the same way every way, that does increase the reliability of the assessment. Some people might find it more comfortable to be giving information to a computer and not a human who they may fear is judging them or may share the information. Others might find it impersonal, dehumanizing, and not really therapeutic. So even though a clinical assessment, the point is to, in an intake assessment or an interview, the point is to get information, and it is kind of goal-oriented and not therapy in itself, it is still a therapeutic process. You still want to make the person feel heard. You want to make them feel a little bit better after leaving the assessment, because often when we're doing the assessment, the goal is to get them to come back to another session to continue through with therapy. And if they don't have contact with a human, this may be a little less likely. Another drawback of the computer is that it can only administer structured interviews, can't ask its own like follow-up or clarifying questions, obviously can't pick up on nonverbal cues, which are very important in a clinical setting, and the patient needs to respond in a pretty specific way, so with close-ended questions. And this brings us to rapport, which is the relationship between the clinician and the patient. So in the situation where a computer is doing the assessment, there's obviously no rapport. And rapport is often considered to be the most essential part of the assessment interview. It's what brings a person back to come back for therapy. It's what allows a client or a patient to divulge personal information. It allows the patient to trust the clinician. And this is backed by research. This is backed by a kind of wide body of research that suggests that rapport is one of the most active and important ingredients in most therapeutic processes. Rapport can have a lot of different components, and that can vary between different clinician-patient pairs, but some important aspects are acceptance on the part of the clinician, acceptance of the patient, empathy, understanding, respect for the patient. So being condescending or talking down to a patient is an instant rapport killer. Rapport is different than being well-liked. A lot of people, especially earlier in their career, will try to get a patient to like them and will think that a patient is most concerned with them being competent and cool and being liked as a person. And while these can be helpful sometimes, they're also not as important as clinicians seem to think. The patient typically just wants someone to listen to them, to certainly be competent, but also understanding and respectful of where they're coming from. Strong rapport, if there is strong rapport between the clinician and the patient, this can kind of allow the clinician to speak a little more freely. So if a patient trusts you, you're able to be a little more direct sometimes. You can gently challenge the patient sometimes when needed. So if the patient's leaves, comes back at shows up at every session and hasn't completed like the homework or the activity that they were supposed to do between sessions, this is something that at the beginning of a relationship you might not address very assertively, but as rapport is built and as trust is built, you might be able to be a little more assertive in kind of questioning why the homework isn't happening. So communication is rather formalized, often in the interview process. It's good to begin a session with casual conversation. So often on the way back when I get my new patient, if I'm doing an intake interview, for example, at my current clinic, I will get the patient from the waiting room and kind of just ask them, did you find the place okay? Any trouble getting here? If it's particularly rainy, I might talk about the weather, which sounds really boring, but it's just kind of a way of showing that I'm a human, and start kind of breaking the ice a bit. It's important throughout the interview and throughout assessment and therapy in general to match the patient's language. So I work in West Baltimore, which is a pretty rough area of Baltimore, and people are, in general, the patients I work with are very low income, low education. And if I'm using a lot of complex terms and a lot of, for example, if I used slang from Hawaii, this would not really make sense to the patient. And if I'm using complex terms, the patient might feel distanced from me or feel that I'm patronizing them. And then often my patients will have local lingo that I'm not familiar with because I've only lived in Baltimore for 4 months, and they have their own set of lingo and slang. And so the best way to deal with that is to just be really honest about that. So almost always I end up divulging to people that I've just moved to Baltimore a few months ago, and I'm going to need them to clarify like what they mean by the use of a certain term, or they'll have different names for like areas of the city that I'm not familiar with. The use of different types of questions can be very important. So there are open-ended and closed-ended questions. Open-ended question would be like, how was growing up for you? How was school for you growing up? And a closed-ended question would be, did you finish 12th grade? You want to be facilitative with questions. You don't want to be leading. You would want to ask something like, you said your father was abusive growing up. How are you dealing with that now? Rather than, you said your father was abusive growing up. Does that make you sad now? You don't want to lead them into a certain answer. Clarifying questions are great. It's really important. A lot of times somebody will say something, you think you know what they're meaning, but you ask a follow-up question and find them at something completely different. Confronting questions I kind of touched on before. This is something that you have to be very careful with. So sometimes it is important to be pretty assertive with somebody. Sometimes for you to understand what they're trying to say, you have to be kind of candid with them, but you have to be very careful with this. And that's kind of the same with direct questions. Silence is something that is a tool that can be very challenging to use. So silence has meaning. Silence can mean that somebody doesn't want to answer a question. So if you ask a question and there's silence, there's not an answer. It can mean they don't want to answer it. It can mean they're thinking about it. It can mean that they are kind of playing with the power dynamic and seeing if they can just not answer questions. So when I used to work with teenagers at the early psychosis clinic in Hawaii, sometimes if teenagers were kind of being forced to be there and didn't necessarily want to be there, they might just not answer questions. And so as a clinician, you have to decide whether to sit with the silence and sort of let the silence do its work, either by allowing people time to answer the question, to think, or sometimes you can sit with the silence even if the silence is on purpose. Even if, for example, if the teenager is not answering the question because they're being, they don't want to be there and maybe they're trying to be a little bit defiant, sometimes you can make them uncomfortable enough that they answer the question anyway, just by sitting with the silence. And obviously the flip side of that would be sometimes it's best to ask another question. So if you detect that silence is there because the individual is uncomfortable, very uncomfortable with the question, it's maybe just too much for them right now. So if you're asking about trauma and somebody just gets very tearful and kind of looks away and looks like they don't want to answer the question, I think in that case it can often be fine to say, would you like to move on to another question? Especially in an intake interview, because trauma or very, very deep personal wounds are often best dealt with on a person's own timeline when they're ready to talk about it. Listening is obviously incredibly important. All the basic skills of listening, looking somebody in the eye, but not too much, not laser eye contact, but frequent eye contact, nodding, giving the I see, okay, those types of kind of verbal indications that you're listening to what they're saying. And then you also communicate in who you are as a clinician. So your appearance, it's important to be to look professional, but not. It may be best to not be too professional. So if someone's sitting there in a suit, like in this little cartoon, the guys are wearing suits, and I think that can actually be rather intimidating to clients. It's maybe better to do business casual, not too casual to where they think you're just some person off the street, but also not too formal. Values, attitudes, and beliefs are something that we impart, something that we express without knowing it, and can often express in how we dress as well. And as I mentioned before, kind of what you divulge about yourself through your office, through the setting of the interview. And so those are things that have to be attended to and kind of carefully thought through. So it's important to consider the patient's frame of reference, or kind of their perspective of why they're there and what kind of services they might receive. So you want to know why they're seeking help. Even if somebody else made the referral question, even if a psychiatrist referred them to you for treatment of depression, you want to know why the client feels that they're coming to you. You want to know if there's any pressure. So if a judge is sending them there, if I mentioned before that I've worked with teenagers that don't want to be there, that their parents making them come. You want to know about their goals. So not just goals in terms of, feeling less depressed, but also just their general goals in life and their beliefs about therapy and therapists. There are many cultures that understandably feel that most models of psychotherapy or psychological help were formed by Western white culture, and that some people feel that it has not been appropriately applied or appropriately accommodated for their culture. And as well, some people may just feel that psychotherapy is not helpful to them, not something that's going to be helpful to them for a variety of reasons. And I think this is entirely understandable and may certainly be true in a number of cases. And it's important to know if somebody feels that way, so that you can kind of work with them and see what you can do for someone that comes in with that kind of set of beliefs. The clinician's frame of reference is, of course, important as well. So as a clinician, you want to make sure to review materials beforehand. If you have any records, like previous medical records, if the referral source, so if the psychiatrist or the social worker or someone sent over their notes, you want to read those and kind of get a sense of what treatment has been like for this person thus far, or if they, like relevant medical history if they haven't been in psychological treatment before. When they come in, it's very important to be clear about the purpose of the interview. So many people, especially if this is their first contact with psychology services, really don't know what to expect. And I think it both alleviates sort of anxiety and also just helps the patient understand why you're asking the questions you're asking, and helps them provide more relevant and maybe even more like open answers to your questions. It's important to remain focused. This can be very difficult. So it's typical that we have a limited amount of time in intake sessions. So the clinic I'm at right now, we have an hour and a half as the therapists have an hour and a half for their portion of the intake session, which is great, and it's the longest intake I've ever been allowed. At a previous clinic that I worked in over in Waianae, we had 30 minutes to figure out why the person was coming in, and that's quite a challenge. And so we had to remain very focused during that time, kind of not let tangential stories and things like that go on too far. And then at the end of the intake, you want to provide some closure to the person. You want to say what's going to happen next, thank them for their time, and make sure that you ask them if they have any questions for you in terms of what's going to be done with the information or what the next step is in the process. There are different types of assessment interviews, and I've talked about them already a little bit, but I'm going to go over them again briefly. So the intake interview, or like the admission interview, is there to help determine why the patient has come to the clinic or hospital, to get a sense of whether the treatments and resources that are available at that clinic are appropriate to the individual and if they'll be able to meet the needs. So for example, if somebody comes to my clinic who has really, really low cognitive functioning and is kind of unable to answer questions and might benefit more from a behavioral therapy or somebody like in-home help with their completing like daily activities, that would not be appropriate for my clinic. I just wouldn't be able to help the patient in the way that they deserve. And so if someone came in with that presentation, I would refer out to an agency that's better able to meet that person's needs. The intake interview is also there to inform the patient of what the clinic does, how much it costs, policies, procedures, who the different people are. So a big part of my intake interview, usually at my current clinic, is explaining that like I'm a clinician, I do psychotherapy. You would come in here and talk about feelings and how we would look at kind of things that aren't working well in your life and come up with a plan to make things better. And kind of work through maybe any traumas that you've had or any past experiences that are causing you problems now. And then I'll also explain that they're going to see the psychiatrist later, and the psychiatrist is someone who is a medical doctor who prescribes medications, and the psychiatrist will be asking them more about their medical history, and we'll be talking to them about whether there may be medications that could help them improve their psychological functioning. And this is extremely important, especially in places such as where I work in West Baltimore, where people may not be very familiar with the psychological process. If we were in a more affluent area, maybe up in like the New England area, people are generally familiar with what a psychologist is, what a psychiatrist is, and what they can expect. But you can't assume that of a patient coming in a lot of areas. I've included links to YouTube videos for some examples of kind of like intake interviews. People also call them like diagnostic interviews because usually you have to come away with a diagnosis of the patient in order to engage them in services. I can't promise that these are perfect. For some reason, there just aren't a lot of good interviews. Oh, no, I know why. Okay, so there aren't a lot of good interviews, examples of interview videos online because they're either they're almost invariably role plays where the person is not a real patient because of course there are a lot of ethical issues with confidentiality of using a real patient in an online video, and so usually it's people role playing a patient and they're not the best actors. And also it's just kind of awkward. I would hope that somebody's actual intake sessions are not as awkward as these videos, but it's kind of interesting and shows you how it might go down if you've never seen an intake interview before. Case history interview is a little more broad, so you're going to get more context and background of the patient. If it's an adult coming in, you're going to ask all the way back to childhood, which you usually do in an intake interview anyway, but you're going to ask in more detail for the case history interview. So this is something that might be used when somebody comes in with a rather complex problem, or a problem that's been attempted to be treated in the past but hasn't worked out, and maybe you just need more information. Maybe a more detailed case history is necessary to understand the nature of the issue. This can also include informants. So informants can be used kind of in any of these interviews, in the intake interview sometimes, especially if a younger person is coming in. We'll use the parents as an informant. Informant just being anyone from the patient's life who can provide additional information about the patient's functioning. This can be incredibly helpful. And it's kind of one of the benefits of working with people under the age of 18 is that usually you do have the parents or guardians as an informant. In a normal adult interview, you're just working with whatever the adult's willing to tell you and kind of the adult's perception of the situation. And if you have an informant, you have this other perspective, an outside perspective, and it may or may not be more correct than what the patient is telling you, but it's at least another set of information that you can use to try to get a better sense of what's going on. Another type of interview is a mental status examination, which is kind of behavioral observations, and also some assessments can include objective assessments of an individual's cognitive functioning. So this often includes like general presentation, how they appear, if they're dressed appropriately. So is it the dead of winter and they're wearing shorts? Are they wearing kind of bizarre clothing or bright, insanely bright colors that wouldn't be culturally appropriate for where they're living? How are they behaving? Were they rude to front desk staff? Were they are they sitting kind of like as far as they can from you in the office, or are they sort of sitting at kind of a more normal interpersonal distance? Attitude also, are they willing to answer your questions? Are they kind of begrudgingly answering them or not answering them at all? You may talk about, or you would assess for a state of consciousness, whether they seem alert, whether they seem too alert, so maybe like kind of manicky, or maybe that they may be on stimulant medications, or lethargic. So often the people that come into our clinic, it's relatively common to be suffering from opioid use disorder. Probably everyone's familiar with the opioid epidemic right now, and Baltimore is certainly suffering from this. And so often I get people coming in who are kind of too sedated to even answer questions. And so that would certainly be something I would note during the mental status examination. Attention and concentration. So if you have someone with ADHD, they're going to have trouble paying attention and answering all your questions. They might get easily distracted, difficulty concentrating on what you're saying. You want to see how clear their speech is, if it's goal-directed or very tangential. So for somebody with schizophrenia, we're looking for, or just in general, if you want to see if somebody has kind of a psychosis-like disorganized speech pattern. People with schizophrenia, which I think most of you know, often have disorganized speech. So they'll go off on tangents and kind of have difficulty discerning what you're trying to say. It'll just seem like you're kind of talking past them. So you're assessing for this as you're doing the interview. Also looking for language deficits. I've worked with a woman who had traumatic brain injury, and it affected an area of the frontal lobe that was impacted, that impacts language, and she had difficulty finding words, quite a bit of difficulty finding words. She'd kind of take 20 seconds to find words relatively frequently, and so I would note this during my assessment. Orientation of person, place, or time, and there are kind of formalized ways to do this. I'll show you an assessment in a moment where you ask explicitly, do you know what day it is? Do you know where we are right now? Like, what's the name of this clinic? You might ask what time of day it is. In one of the assessments, you ask who the president is and kind of get a sense of if they're sort of oriented to the world around them. And then taking note of mood and affect. So mood is like the emotions that a person is experiencing, and affect is what you can see. So we talk about facial affect a lot, whether their face looks sad, whether their face looks happy or neutral, and whether their face changes according to the content of what they're talking about. So if they're talking about a really great time they had this past weekend, do they seem happy? Does their face look brighter? If they're talking about the death of their mother when they were young, does their face look more sad? I kind of already talked about thought disorder. Formal thought disorder is something that's associated with psychosis. Thought content. So a lot of times people will have a preoccupation with a certain topic, and that's something you want to note. They'll be obsessed with something, and this can be indication of a variety of different disorders, such as like obsessive compulsive disorder. Somebody might be obsessed with cleanliness. In anorexia, somebody might be obsessed with food or the shape of their body. In the case of people with psychosis, we look for delusion. So we try to get a sense of if they think everyone's out to get them, such as in paranoid, a paranoid delusion. And these are things that are assessed through the interview, but you also just, in more formal ways, so you might ask explicitly in part of the interview, do you feel like anyone's out to get you? Do you feel like people watch you everywhere you go? But then you also just pay attention to how they talk about themselves and the people around them throughout the rest of the interview to assess for thought content. You want to look at the ability to think abstractly. So are they very concrete? Do they only talk about what's in front of them? Or are they able to kind of think about the future, think about abstract concepts? And this can be challenging. There are formal ways to assess this, but this can be a rather subjective assessment. Sometimes you might notice that somebody is attending to things that are not there. So, or responding to things in the room that you cannot see. So especially in working with psychosis, the individual might respond to voices that they're hearing. They may be kind of like looking, next to you or looking at something that they're seeing that you're not in the room, and so you want to make note of that. You also want to make note of memory. If they seem to have problems remembering things that you just talked about or seem to have a lot of difficulty recalling things from their past. Intellectual functioning, which is something that we assess formally with with cognitive tasks, but it's something you can kind of note. Are their ability to communicate, do they seem to have cognitive abilities commensurate with their education? In general, do they seem to understand what you're saying without you simplifying it too much? And then finally, insight and judgment are really important. So a lot of times people come into the clinic and say, nothing's wrong with me. I don't know why my psychiatrist, or probably they're not seeing a psychiatrist if they think nothing's wrong with them, but I don't know why my primary care physician sent me here. He just said I should come. And in the interview you find out that there are, or maybe in their records, you see that there are a lot of issues with this person. They might be using a lot of drugs, they might have psychosis, they might have pretty severe depression, and so in that case, the conclusion would be that they have a lot of problems, but they don't really have insight into these problems. Or a lot of times, especially people with drug use problems will acknowledge that they use a lot of substances, but say, but it's fine, I'm functioning. Whereas in their life, they're losing their job, they're not going to school, relationships are falling apart, and so they may not have good insight into how their drug use is impacting their actual functioning. This is an example of an objective measure of mental status. So typically a clinician will be kind of keeping an eye open for all these mental status components throughout the interview, but can also administer a formal assessment. And this one is called the MOCA. It's open to the public, which means you can use it without paying for it, but you shouldn't use it if you're not a trained clinician. It's one that I think psychiatrists like to use a lot. Psychologists use it often too, but tend to favor longer tests. But it's more of a screening just to see if there's any cognitive impairment, any indication of like more cognitive impairment. Interestingly, and without getting too political here, this is just a side note, some of you, if you follow politics, might remember a couple months back, maybe even a year back, where some people were questioning the mental capacities of the President of the United States, and the treating physician for the President said that he had administered an exam, a cognitive exam, and the President got a perfect score, got a 30 out of 30. And this was the exam. It was called the MOCA. And the reason I bring this up is that I think it was actually used rather inappropriately. So it was framed as a cognitive exam, and it's really a cognitive screening. It's an assessment for dementia. So most normal, healthy people should be getting a 30 out of 30 on this. You might notice down in naming, somebody just has to simply, to get a point, you just name, like, that's a lion, that's a rhinoceros, that's a camel. Another one is drawing a clock, and that's looking for severe neurological deficits. So this is not an intelligence exam. It's not a comprehensive cognitive assessment. It's a screener for serious neurological disease that's used in a clinical setting. It's a 30 out of 30 is not an indication that a person's a genius. It's an indication that they probably don't have dementia. So another type of interview is the crisis interview, which is kind of a type of intake interview, but it's a little more oriented toward helping someone who is in an acute crisis. This is common in emergency departments or walk-in clinics, and it kind of meets problems as they occur and is focused on getting resources for that individual. So a lot of times my clinic is right next to a large medical center where there's an emergency department, and there's a psychiatric services section of the emergency department. And often people will come in if they're really like in acute stages of mania. Somebody usually would bring them in if they were in the acute stages of mania, if they might be extremely psychotic to the extent that they may be a danger to themselves or other people. Another really common one is suicidal ideation. So somebody's feeling, having thoughts of hurting themselves, killing themselves, but they have some ambivalence, and so they come into the emergency department to get immediate help with these very serious issues. The point of the crisis interview is to detect how likely it is that something very bad is going to happen, and encourage people to enter appropriate levels of treatment. So if someone comes into the emergency department with thoughts of suicide, the person who's doing the interview is going to determine to what degree that person is likely to attempt suicide. And there are formalized assessments for doing this, but also some very skilled people are capable of doing this without a formalized assessment. You're going to look at whether that person has guns in the house, if they have an idea or a plan. So if somebody has a plan to hurt themselves, it's much more likely that that's going to happen. And often if they have a plan, or if it's determined that it's severe enough, that their suicidal thoughts are severe enough, they will be brought into the inpatient unit for observation to kind of keep them safe and try to help start to resolve whatever issues are driving them to want to hurt themselves. If often a person will come into the emergency department and they won't be in as imminent of danger. So they might be having some kind of like passing thoughts of hurting themselves, just like feeling really stressed out. So okay, so an example would be I had someone that I later saw at my clinic who had come into the emergency department the night before, and his grandmother had just died. And he kind of had a long history of feeling suicidal and feeling depressed often. And so he was feeling kind of actively very like he might impulsively do something that he shouldn't do, might impulsively hurt himself. And so he came into the clinic, he came into the emergency department and told this to the psychological services there, and they were able to determine that he was kind of in an acute crisis, and they were able to sort of talk him down. He had a lot of internal ability to get himself back down to a place where he said, okay, that was just like a kind of a strong reaction to hearing about my grandmother's passing. I'm feeling better. And they kept him for a little bit. He seemed like he was feeling better. They sent him back home. But they set him up with a referral to my clinic so that we could work on some of the more long-standing issues of, when something bad happens, why do you feel like you want to hurt yourself? And start to look at some of that depression underlying a lot of these feelings. And so the crisis interview can lead to a variety of interventions, whether admission into an inpatient facility or referral to other resources. And crisis interview, I think it goes without saying, it requires a lot of sensitivity, a lot of training and experience, and good judgment. People can come in various states of agitation and depression, and people can come in with guns. People come in with under the influence of really serious drugs and can act in ways that are unpredictable. And so a clinician who is doing one of these interviews should be very well trained. Diagnostic interview, it's kind of unusual to me how your book's author kind of separates this from the other interviews, because I think often the other types of interviews are also diagnostic. The point is to make a diagnosis. But in general, when you're making a diagnosis in an interview, there are two general forms. There's unstructured, which is free form, and content can vary a lot between clinicians. Clinicians have different ideas about what's most important to talk about. There's also structured interviews. So there's, I had shown you one before, the SCID, which we talked about, which is a structured interview for the DSM 4 and now 5. We talked about that in the previous chapter, which has a standard set of questions and follow-ups that you ask in a specific sequence. The benefit is that all patients are asked the same question, so a clinician won't forget to ask about something like mania or drug use. And it's more likely in using a structured interview that two clinicians will come to the same conclusion. So that has higher inter-rater reliability, which we talked about last section and we're going to talk about again in a minute. So reliability and validity are something that we're likely going to end up coming back to a number of times. It's extremely important in clinical work. Reliability is the consistency of a measure, whether or not it produces the same results or at least similar results under similar circumstances. So we talked about inter-rater reliability before, which is the level of agreement between two raters who have evaluated the same patient independently. So if me and my colleague across the hall both did a diagnostic interview with the same patient, would we come to the same diagnosis? And kappa coefficient is a statistical index of inter-rater reliability. I'm not going to test you on that. That's kind of advanced. And retest reliability is the consistency of interview scores over time. So if a person is taking the same test, so if I've administered the AMOCA to an individual now and administered it to an individual in a week, assuming that the patient has the same level of cognitive functioning now and in 1 week, would I be getting the same test results from the MOCA? Validity is how well the measure is indexing or measuring what it intends to measure. So content validity is the degree to which the interview items actually measure the various aspects of that construct. So for the MOCA, the cognitive assessment we talked about just earlier, the content validity would be the degree to which the MOCA actually assesses cognitive functioning in an individual, kind of rough cognitive functioning individual. Concurrent validity is the extent to which interview scores are correlated to a related but independent set of interview scores or behaviors. So if two measures are trying to assess the same thing, so we'll just go back to the MOCA. If I administer the MOCA to an individual and then there's another assessment called the mini mental status exam, which is supposed to assess the same thing. It's just like a version of the MOCA that asks similar questions, but you have to pay for it. Would I get similar scores for the same patient on those two tests? And that would be concurrent validity. And then predictive validity is the extent to which an interview scores or an assessment can predict behavior or test scores that are observed or obtained at some point in the future. So if I'm administering the MOCA, To what degree does that predict cognitive functioning in the future? To what degree does that tell me about the prognosis of that individual? There are a number of ways to ensure reliability and validity in a clinical interview. Whenever possible, it's best to use a structured interview if reliability and validity are a concern. It doesn't necessarily have to be the SCID, the one developed for the DSM. It can be one that's been developed for a clinic. So different clinics that I've worked in all have their own version of an intake interview based on what they think are the most important questions to ask of people coming in. Good interview skills are, of course, very important, and making sure that all clinicians have good interview skills. Being aware of patients' motivations or expectations. So if a patient's coming in and their motivation is to get psychological services because they're want to get some kind of benefits that they may or may not be appropriate for, it's good to be aware of that to better help you interpret what the patient, the reasons for what the patient is saying. And also being aware of one's own expectations of the person coming in, biases toward different types of people, and cultural values.